Hello and welcome. Hi. So let's start this session of ENT. So once again, welcome to this session of ENT. And today and tomorrow, we're going to discuss how many questions? I've given you 75 questions. But tomorrow after the class, depending on the responses, I might discuss few bonus questions also. Bonus questions, extra few questions. That depends. We'll see tomorrow at the end of the class. Okay. Now, before I start, I must tell you that if you have any questions, any doubts, please write in the Telegram group, the Test and Discussion 2024 group. I'm sure most of you have joined that group. And don't write anything on the YouTube channel, on the channel that you're watching, because I'm not watching that. I can't see that. So if you write anything there, I'll not be able to see or answer that. So any doubts, question, anything in the Telegram group. So like I was saying, we have how many? We have 75 questions, and tomorrow after the class, God willing, we'll discuss few more questions, bonus questions like I said. So straight away, we'll dive into the first question. So this is a question based, image based question of the ossicles, or you can say image based question on the middle ear. And if you have been following the last few years questions, you'll know that middle ear image based questions are very regular feature. Since COVID, almost every question paper, if I remember correctly, has a question based on middle ear image, either middle ear image or ossicles directly. So this is exactly the same thing, a question on ossicular chain. So you can see the arrow, and the question is, based on this arrow that you see, you just have to find out this structure. So they are telling you this is a joint with the stapes. So either you can identify by the image, and if you do not know the image, if you cannot identify the image, then if you know the which part of the, because stapes, who forms joint with the stapes? Incus, right? So which part of the incus forms the joint with the stapes? That means if you do not know the image also, or if you cannot identify the arrow mark structure on the image, if you know this theory, you can still answer the question. So guys and girls, what is the answer? So tell me, is it handle of malleus, long process of incus, lenticular process of incus, short process of incus? So what do you want to say? Please answer this question. So like I said, depending on your responses, I'll be able to decide, should I discuss tomorrow extra questions or not, besides the 75 that you have written. So you must answer A, so that I know whether you've understood the question or you know the questions, most of you. If you're not answering, then the impression I get is that you don't know. If you're answering a lot of them, then I know that you know the answer. And so as many of you rightly said, C is the correct answer. So this was correct. Raj, Som Subhra, Shukna, Som Subhra again, Somit, Soumya Jha, Divyans, Aditi, Satyendra, Sneha, Ajay. So everybody who has answered lenticular process is a correct answer. Now in this image of the middle ear or ossicles, what are the important structures that you should be able to identify normally? The important points. See, this whole thing is malleus, I'm sure you know. And in the malleus, this is the head of malleus. This one is the neck of malleus. This is your anterior process. This process goes anteriorly, anterior process, and this process is the lateral process. This is your handle of malleus, and this tip is the umbo. So these are the parts of the malleus that one should be aware of: head, neck, lateral process, anterior process, handle, umbo. The other parts also, but these are the prominent ones that you can see in most of the images. The next ossicle, this one, this is the incus. Now this is the body of incus. This is the short process of incus. This is the long process. And as most of you have identified, this, the one that is forming the joint with the stapes, is the lenticular process. So these are the parts of the ossicles that you should be able to identify. Part of the incus easily: body, short process, long process, and lenticular process, as you can see, forms the joint with the stapes. Now which part of the stapes forms the joint? The part of the stapes that forms the joint is called the head of the stapes. Next is the neck of stapes. These two curved bones are called crura, and last thing is the footplate of stapes. So if you know these parts that I have told you, you know all the important parts of the ossicular chain or ossicles that you are supposed to know. Now there are two more things in ossicles that one should be aware of. Joints. This is one joint between malleus and incus. This is the other joint between incus and stapes. The joint between the malleus and the incus is the saddle joint, and the joint between incus and stapes is the ball and socket joint. Again, these are very important MCQ. Yes, Vignesh, incubomalleolar joint is saddle joint. You are right. Incubostapital joint is the ball and socket joint. Absolutely correct, Vignesh. So this will take care of all the important things about the ossicles that you need to know. And then we proceed on to the next question. Question number 2. Which of the following is not true of head and neck carcinomas? So head and neck carcinomas are a very important topic in ENT. Lately they've been asking a few questions from here, and so I've combined 3 or 4 different questions that have been asked and created one question out of it. This one question is actually asking you about 3 or 4 different questions. So HPV 18 is the most common etiology of laryngeal carcinoma. Post-cricoid carcinoma may be seen in ladies who have Plummer-Vincent syndrome. Lymphadenopathy is the most common presentation of nasopharyngeal carcinoma, and most common site of oral carcinoma in India is buccal mucosa. So which is not true, and I already see people writing answers. So Som Subra is saying A, Sukuna is saying A, and Raj is also saying A. So what do you think, guys? A? So I'll really request more people to answer so that it gives an idea. According to your point of view, is the question difficult or easy? So if most people answer correctly, then I think it's an easy question, so I will not spend too much time. And if most people answer wrongly, then I feel it's a difficult question, I spend more time explaining. So that it gives you a feedback actually about you. So again, a lot of A's coming up: Raj, Sneha, Satyendra, Soumit, Aditi, Vignesh, Sneha, Harshit, Soumya Jahan. Yes. So A is a correct answer, absolutely. If you read, now why is this important? Because if you read old book, in old book, let's say 10-15 years back, HPV was considered as a very important etiological factor for laryngeal carcinoma. Only about 10-15 years back, it has been conclusively indicated that laryngeal carcinoma has no viral etiology. Although laryngeal papilloma is caused by a virus, human papillomavirus 6 and 11, but not laryngeal carcinoma. So the way to remember is that the only head and neck carcinoma which does not have a viral etiology is a laryngeal carcinoma, right? Now post-cricoid carcinoma among the head and neck carcinoma is the rare carcinomas which is more common in ladies, females. Otherwise, most of the carcinomas of the head and neck are more common in males. And this carcinoma is seen in people who have had Plummer-Vinson syndrome, which is also called Patterson-Kelly syndrome. So Plummer-Vinson syndrome is like a pre-malignant condition in these ladies who can have post-cricoid carcinoma. Nasopharyngeal carcinoma is an extremely important carcinoma, nasopharyngeal carcinoma. And there are 3 or 4 MCQs from here, which we have more questions, I believe. But lymphadenopathy is the most common presentation. It's a very popular MCQ. And although in oral cavity carcinoma, rest of the world, if they ask which is the most common site of oral cavity carcinoma in rest of the world, then the answer is lateral border of the tongue. But in India, it is a different answer. In India, it is buccal mucosa, and this is predominantly because the habit of eating tobacco. In India, there is a very common, you can say a bad manner, you can say uncivic thing, where people eat a lot of tobacco, which is called khaini. So they place the tobacco in this below the buccal mucosa, below the gum and the buccal mucosa, and that is the cause of carcinoma in India, and that's why this is important. So that much about the carcinoma. We have more questions coming up with related to carcinoma, so we'll discuss all of them. But in the meanwhile, we shall go to the third question. Third question, try to answer that a 13-year-old boy came with multiple episodes of bleeding from nose. Nasal endoscopy image is shown. Which of the following condition is most likely responsible? So this is an AIMS question from last AIMS exam question, this one. So straight away, I think you can answer this question easily without any problem. A 13-year-old boy came with multiple episodes of bleeding from nose and nasal endoscopy. So I can see a lot of Bs coming up. So right from Ajay, Somsubra, AM, Vignesh, Sukuna, Rohita, Satendra, Soumya Jahan. Yes. So the moment you see this line that a male child in the juvenile age group has epistaxis, bleeding from the nose, the first thing that comes to your mind is juvenile angiofibroma. And this is a very typical endoscopic image of a juvenile angiofibroma. In this image, you should be able to identify 3 things. What are the 3 things that you should be able to identify in this image? 1, you should be able to identify inferior turbinate. IT is the inferior turbinate, and this is the septum. So obviously in the nasal cavity, one side you can see turbinates, one side you can see nasal septum, and between the 2 things there is a nasal cavity, and between these 2 there is a mass, and this mass is in the posterior part of the nose, and this is called juvenile nasopharyngeal angiofibroma, right? So that's how you get this answer, easy. Now antroconal polyp also is seen in males, also seen in juvenile age group, but it is not seen in males. So let me put it here. Antroconal polyp is also seen in children, juvenile age group, but no bleed. It never bleeds, and it is pale in color, pale mass. So it cannot be polyp because everything is opposite. The look is different, the history is different, only the age is same, nothing else is common. Now foreign body, usually there is a foul smell. Foul smell is more common than bleeding. Bleeding can happen, of course, but smaller children, they are seen in smaller children, not around 13 age group. Usually foreign body is not seen. And allergic rhinitis, usually no bleed. In allergic rhinitis, usually there is no bleed, and there is itching in the nose and sneezing. In allergic rhinitis, we have a question on this, so we'll discuss that one. So all these diseases are very different from each other, and that's why it is very easy to rule out other causes in this particular case. So very easy to answer this question. Now angiofibroma, in this list that you see of all the choices, angiofibroma is the most important topic from the exam point of view. They've been asking questions from angiofibroma very regularly, and these are the other important points we can read of angiofibroma. So I just lot of things I've just taken a screenshot of the class notes. When I teach, I make notes, I write notes. So I've taken a lot of class notes screenshot, and I'm giving you this kind of a screenshots so that you can get the extra points about that particular disease. So if you see here, angiofibroma presents this, the history is almost the way it is written in your question. It's a very similar history. Epistaxis is the most common complaint, but besides epistaxis, there can be cheek swelling, there can be proptosis. When cheek swelling and proptosis are together, this becomes frog, it is called frog face deformity. Now frog face is a very important MCQ. Then there is antral sign, which is called Hallman sign. This is another very important MCQ. Sometimes they ask you an image of this. So what is antral sign? In antral sign, there is anterior bowing of posterior maxillary wall. I'm sure you know this. I'm just it's kind of revision. So most of this information are very regular information. Most people know this. It's like a revision. And endoscopy will show a red mass in the quena, and this is exactly what that image showed. Endoscopy, there was a red mass in the quena, and CT scan can show you three things. Antral sign, this one, this is the antral sign, which can be seen on CT scan. CT scan can show the erosion of the sphenoid of the greater wing. GR wing means greater wing. So CT scan can show the erosion of the greater wing of the sphenoid, and it can also show you what is called salt and pepper appearance. So this is CT scan, and the same, this salt and pepper appearance on CT scan is called bag of worms on MRI. So if you do MRI, the same finding is called bag of worms, and you can do DSA, digital subtraction angiography, and biopsy is contraindicated. Biopsy is contraindicated. So these are the other important points about angiofibroma. And Vignesh is asking me that show the image of the first pass endoscopic picture. So when you do endoscopy, nasal endoscopy, has three passes. That means we pass the endoscope in the nose three times. We put it, then take it out, then again put it, and then take it out, and then put it, and then take it out. The first pass is inferior meatus, and you can see nasopharynx in this. The second pass is the superior meatus, and the third pass is the middle meatus, right? So these are the three passes of the endoscopy. Now the image is not important. I don't know why do you want to see the image. I don't have it in this particular slide. I don't have the image of any of these passes, so I'm sorry I can't show you. But if you actually want to see the images and be explained about this thing, then after the class you remind me, give me a message on the same thing. So I'll get an image for you, and maybe tomorrow I can discuss, or after the break, when we take a break, if you give me the message during the break, after the break I'll show you. But I will forget, so you have to remind me, otherwise I'll forget, right? Yes, there are other things also. Hondusa sign. Somebody says Hondusa sign is also one of the features of angiofibroma. There is also in angiofibroma Hondusa sign. But Hondusa sign is a very uncommon sign. Hardly ever, I don't ever remember it has been asked ever, Hondusa sign. But yeah, this is definitely a sign. So you can try and remember that Hondusa sign also. Next we go to question number 4. Now this is a very simple question. It's an image based question on audiogram. Audiogram is a very important topic. I've been asking questions regularly on audiogram. So audiogram you really have to know. So a 30-year-old pregnant lady with hearing loss, the following audiometry findings, which of the following sign is seen in this patient? So Carhart's notch, Boiler's dip, AS type, AD type. So I can see a lot of A's here. Som, Subra, Vignesh, Som Subra, again Ajay, Yuganta, Soumya, Rohita, Soumit, Sutendra, Raj, everybody, it is correct. So these two are audiometry finding and these two are tympanometry finding. So straight away these two are out because this is a audiogram. It's written also audiogram. It's not a tympanogram. So C and D is absolutely out. So it has to be one of the two. And this is a Cahardt's notch, as most of you know already. In Cahardt's notch, as many of us saying, there is a dip at 2000 in BC audiogram and it's seen in otosclerosis. Whereas Boiler's dip is dip at 4000. This can be AC or BC. Like Cahardt's notch has to be BC only. This can be AC or BC, and this is seen in NIHL, noise induced hearing loss. Hearing loss when the patient is exposed to loud noise. So these two that I have given you, the points are regular points. Most people know, but Cahardt's notch, I want you to know few very important points about Cahardt's notch. Now Cahardt's notch is a apparent, Cahardt's notch shows apparent SNH. What does it mean? See, in audiogram we will discuss properly afterwards because we have more questions on audiogram. So when we come to a proper question on audiogram, I'll tell you how to interpret audiogram. We'll discuss all that. But about Cahardt's notch, I'm telling you 3 or 4 points, special points. That Cahardt's notch in audiogram, AC audiogram is suggestive of conductive hearing loss. So if there is a conductive hearing loss, then change will happen in the AC audiogram. And BC audiogram is suggestive of sensory neural hearing loss. So if there is sensory neural hearing loss, SNHL, then there will be change in the audiogram. So because the Cahardt's notch is seen in BC, so that means it is suggesting SNHL, right? So any change in the BC means there is SNHL. But in otosclerosis, there is only CHL, no SNHL. So a disease like otosclerosis which has CHL should have changes only in the AC audiogram, but very strangely in otosclerosis where there is only CHL, there is changes in the BC also. And like I said, any change in the BC is suggestive of SNHL, but in otosclerosis there is no SNHL. That's why it is trying to show there is SNHL, but actually there is no SNHL. That's the meaning of apparent SNHL. Cahardt's notch is a showing apparent SNHL, okay, and it is not true reflection of the hearing loss. That means it is not a true reflection of a hearing loss. आपसे झूठ बोल रहा है, एक तरह से it's a liar, it's lying, right? And as somebody had written that this notch disappears after stapedectomy surgery. So if you do a stapedectomy surgery, the Cahardt's notch will disappear. Okay, so remember that. So these are the 2 points about Cahardt's notch that you should remember, addition to whatever you know. Now, obviously this patient is having otosclerosis. This is a very typical of history of otosclerosis. In otosclerosis, which is a very important topic of year, the history is almost very similar. a 30-year-old pregnant lady with hearing loss. If you read this line, the only thing possible is otosclerosis from the exam point of view at least. Now in otosclerosis, they really ask you a lot of tests. Otosclerosis is a topic where we have to know many points, but what are the type of tests and finding in otosclerosis that you should know? And they really, these are the tests, tuning fork test, audiometry, tympanometry, and the findings, because in otosclerosis they really ask you these questions. I am sure you know this already, but it's like a revision. So try to remember that in otosclerosis, Rhines will be negative, which is BC more than AC. Galleys will also be negative. Negative Galleys is taken as diagnostic of otosclerosis, almost like diagnostic. Mbbs will be lateralized to the same site as disease. Swabex will be better than the examiner, or it will increase compared to the examiner. Pure tone audiometry that we have just discussed will show you Cahardt's notch. Now Cahardt's notch is very similar to cookie bite audiogram. They are not the same thing. Cookie bite and Cahardt's notch, they are not same. They are very similar, and both are seen in otosclerosis. And tympanometry will show you AS type of tympanogram, and this is an investigation of choice. You can also do MRI in otosclerosis, and MRI in otosclerosis can help you know three things. So I am writing here, MRI in otosclerosis will A, help you diagnose the disease. That is one thing it does. Also it tells you the stage of disease, because I am sure you know that otosclerosis has active stage, passive stage. MRI can show you the stage of the disease also. And third thing, it can show you the part of foot plate involved. Part of foot plate involved. Which part of the foot plate is involved? Because depending on part of the foot plate is involved in otosclerosis is divided into 5 types: anterior focus, posterior focus, circumferential, biscuit type, obliterative type. So those types you can know by looking with the help of the MRI. So MRI is really useful in otosclerosis because it makes you help diagnosis. It tells you the stage of the disease, and it tells you the type based on which part of the foot plate is involved. So it can be very, very beneficial and useful. So from here they really ask you questions in otosclerosis, which is an extremely important topic. Other points about otosclerosis we'll discuss as we proceed. We have more questions coming on otosclerosis. Yes. So Ryan is saying that is stop it. I told you here that the Cahardt's notch will disappear after stapedectomy. It can disappear after stapedotomy also. Any surgery you do, in both it will disappear, right? So I think he's trying to ask me that is the treatment of choice or surgery of choice stapedectomy or stapedotomy? Yes, the treatment of choice or the surgery of choice in otosclerosis is stapedotomy. Nowadays we do stapedotomy, and between stapedectomy and stapedotomy, which are two different kind of surgery for the same disease, otosclerosis, there's very, very little difference. There is very minor difference. There's only one step is different. Only one step in the surgery is different. Otherwise, every other step of the surgery is the same. Very mild difference. Yes, we prefer now stapedotomy as compared to stapedectomy, but Cahardt's notch will disappear in both of them. Okay, that's one thing. And after surgery, AS will convert to AD and Cahardt's notch disappears. That is not true. Vignesh is saying that after surgery, AS will convert to AD and Cahardt's notch will disappear. Cahardt's notch will disappear is true. The second sentence is true. The first one is not true. AS tympanogram does not become AD tympanogram, because after all, you have like repaired the ossicular chain. In otosclerosis, what you are doing? You are kind of repairing the ossicular chain. So if you repair the ossicular chain, you get AD tympanogram only when the ossicular chain is damaged, disrupted. But if you repair the ossicular chain, like in this case, you are kind of repairing it, you are putting a prosthesis, then you do not get AD graph. So if you have read this somewhere, it is a wrong information. Please correct in your brains. Okay, that is a wrong information. Now, HRCT, halo sign, double ring sign. I think halo sign, double ring sign on CT scan can be seen in a otosclerosis foot plate, not all type of them. It is only seen in some type of otosclerosis, not all of them. And CT scan is not a very good thing for otosclerosis, because otosclerosis patch of very focus is very small, simple, which is better picked up on MRI, not so much on CT scan. So I'm not too sure about this. Then theory is important to remember in JNA. Yes, Sukuna, the theories of JNA are important. The names of the theories. Okay. JNA, remember names of theory. Don't have to remember the whole theory. One is Osborne theory, you have to remember, and one Sick and colleague theory. So remember these two names only, theories. Don't have to remember there are 11 theories actually. You don't have to know, because these are the two most acceptable theory. Rest of the theories are outdated theories. So you don't have to know the rest of them. Then Somudra is asking, a foot plate of stapes is preserved in stapedotomy. Well, not true. Surgery for otosclerosis. You can do two surgeries: stapedectomy and stapedotomy. I told you these two surgeries are very similar to each other. Only one step is different. What is the difference in the two? In stapedectomy, 1/3 of foot plate is removed. Not the whole. Only 1/3 of the foot plate is removed. In stapedotomy, a hole of 0.6 millimeter is drilled on foot plate. So now you decide for yourself. So can I say that in stapedectomy the foot plate is removed? I don't think that is a correct sentence, because the whole foot plate is not removed. Here also we are retaining 2/3 of the foot plate is retained, right? So it is not completely removed. And in stapedotomy also, the foot plate is not normal. You can't say it is absolutely preserved normal, because you are drilling a hole in this. So it's not a normal intact foot plate. So now you draw your own conclusion from here. These are the facts. So this is the only difference between the surgery of stapedectomy and stapedotomy, that when you make a hole in the foot plate, in one case we just drill a hole of 0.6 millimeters. In the other one we remove 1/3 of the foot plate, 2/3 is retained, and otherwise every other step is same in both the surgeries. So I hope this clears if there is any doubt in your minds. Okay. Yes, both the surgeries are preferred under LA. Why? Both the surgeries are preferred under local anesthesia. Why? Because during stapedectomy surgery, after you drill a hole or remove 1/3 of the foot plate, and then you put a prosthesis in place, after that you have to check the hearing of the patient, whether the patient has improved the hearing or not. So you speak to the patient before the patient is out of the table, before you have closed the suture and all. You first check, you speak to the patient and you check whether the patient can hear you or not. Not for facial palsy. Facial palsy के लिए नहीं करते ये करते हैं hearing है कि नहीं है. To check the hearing after stapedectomy, so after both these surgeries, after both the surgery, check hearing or check the hearing or outcome of surgery. we always check the outcome of the surgery and the hearing before we close the suture, right? And for this you can do two things. One, you speak with patient. You speak with patient in a very low tone, very low pitch, in a very low tone or volume. If the patient can hear you in a low volume, that means the patient's hearing has improved. And there is something called light reflex. The second thing that we can do is called light reflex. Now I am not going to explain to you what is light reflex because it is not important, because exam is near. We don't want to talk about things which are not useful to you. Wasting time is not important. But if you can remember, this light reflex can be used to check the hearing or the outcome of the surgery, whether the surgery is successful or not. That should be, maybe that could be useful, but you don't have to know the details of the light reflex. I think enough of these surgeries and otosclerosis, but like I said, otosclerosis, we still have few more questions, few more things to discuss. In the meanwhile, we'll go to question number 5. An elderly male comes with polyp hanging from the nose. He takes a bath in the pond regularly. What is the diagnosis? So this polyp-like thing in the elderly male, you can see, and by looking at the image, you have to make a diagnosis: rhinoscleroma, rhinosporidiosis, Fembicus vulgaris, and nasal polyp. And I can see a lot of B's, B. So Som Subrai says B, Sukuna says B, Somvit, AM, Deepti, Ajay, Rohita, Shivkumar, and like rhinoscleroma, there is no history of bathing in the pond is only seen in rhinosporidiosis, because rhinosporidiosis is an aquatic protozoa, and so it grows in water. That's why in ponds you can see them, because it is an aquatic protozoa. So that is a very good hint for this rhinosporidiosis. And rhinosporidiosis is also called strawberry polyp. It is called strawberry polyp because it is deep red like a strawberry, and if you look at the image, it is exactly that. It is strawberry polyp, deep neck in color. Rhinoscleroma is a bacterial infection. And it has a fibrous tissue. There is a fibrosis of nose. That's why sclerosis, scleroma or sclerotic tissue is a fibrous tissue, and fibrous tissue is not so red in color. It's never so red, fibrous tissue. No fibrous tissue can be as red as you see in the image. And moreover, in rhinoscleroma, there is no relation to bathing in the pond. Then nasal polyps are pale in color, pale, because they have poor blood supply. And once again, nasal polyps have no relation with bathing in the ponds. So this is very clearly a rhinosporidiosis, as most of you answered correctly, and it's called strawberry polyp. The other important points about rhinosporidiosis are these, if you want to remember. So like I told you, it is caused by Rhinosporidium siberi, which is an aquatic protozoa. So in southern India, it is more commonly seen in the coastal areas. In the northern India, it is seen in farmlands because of irrigation. And strawberry polyp, somebody used the word ripe mulberry polyp. It's okay, ripe mulberry polyp is also an expression that is used. But don't confuse a mulberry polyp and a mulberry turbinate. Mulberry polyp is used for this rhinosporidiosis, but mulberry turbinate is a term is used for inferior turbinate hypertrophy. Inferior turbinate hypertrophy is also called mulberry turbinate. So be aware of that. You cannot culture this pathogen. It cannot be cultured, but histopathology can be done, and histopathology shows large sporangia with endospores. So there are large sporangia with endospores, and there is a eosinophilic matrix. Background, you can see the background is eosinophilic. So pink you will see always the background. And dapsone is a drug of choice is another very important point. In rhinosporidiosis, these are the only points that you should know, that there's nothing else to know. So it's a simple topic, but it's a very important topic. So let's say what Bignesh has to say. He says there's a history of pond, immunocompetent, and southern India it is more commonly seen, that is true. Strawberry or mulberry mass, and etiology is Siberi and wide excision plus post of dapsone. So absolutely correct, Bignesh. This got spot on every point. Good. And rhinoscleroma, we have a question on that. So we'll discuss rhinoscleroma later on. Which of this is true of auditory neuropathy? O is normal but Bera is abnormal. O is abnormal but Bera is normal. Both are normal and both are abnormal. So auditory neuropathy, which of the following will be true? So what do you have to say? I'm waiting for your answers. A, B, C, D. AE is normal, Bera abnormal. Ulta, A abnormal, Bera normal. Both are normal and both are abnormal. So guys and girls, I want you to answer this question so that if need be, we can discuss. And I can see a lot of A. Aditi Goyal is saying A, Soumit is saying A, Satyendra is saying A, Soumya Jha is A, Ryan is A, Ryan, Deepti A, Som Subhra, Raj A, and A is the correct answer. Right. Auditory neuropathy, as the name tells you, is a disease of the eighth nerve. It's a neuropathy of the eighth nerve. So this becomes what is called retrocochlear disease. Eighth nerve disease are called retrocochlear disease. And yes, in a retrocochlear disease, OA is normal and Bera is abnormal. OAE is abnormal in cochlear disease. But in this case, AO is normal, so it's not a cochlear disease. And Bera is abnormal. In Bera, abnormal means increased latency in retrocochlear disease. And because auditory neuropathy is a retrocochlear disease, so Bera will be abnormal, but OE has nothing to do with retrocochlear disease, so it will be normal. So yes, this is the correct answer. Before I explain a little bit more about Bera, there are two statements I want to read. So Aditi Goyal is saying that outer hair cells, which is normal, nerve involvement before Bera abnormal. I could not get what you are writing. Please reframe your sentence properly. And Vignesh in history of child can hear sound but does not understand speech. So Vignesh is trying to say that in auditory neuropathy, the usual history is that there is low speech discrimination. So this is the right thing to say, that there is a low speech discrimination. There are two things in hearing. So since you have mentioned this, let me explain to you something very interesting. This is interesting. See, as it comes to hearing, there are two things: whether one can hear or not. That is one thing. If I give you a sound, can you hear the sound or not? That is one thing. And the second point is whether one can understand the sound or not. These are two different things, right? Now, if you can hear the sound, but you cannot understand the meaning of the sound, what is being spoken, then it is useless, isn't it? So, when you hear a sound, you must also understand the meaning of the sound, what is spoken. If you cannot understand and you only hear the sound, it's like you are hearing a foreign language, a language that you don't know. You're hearing, but you can't understand. So, it's no good. Now, audiometry only tells you the threshold of hearing. This is the information it gives you. This means the patient can hear a sound or not. This is what audiometry says, right? Whereas speech audiometry, there is something called speech audiometry, which we usually don't discuss. This usually tells us whether the patient can understand or not. So, there is a different investigation for that, right? Now, hearing threshold, hearing is affected in every ear disease, almost. It is not 100% true, but almost. For us, this is true, that no matter which part of the ear has a disease, whether it is external ear, middle ear, inner ear, eighth nerve, brain stem, brain, no matter where is the disease, the patient will always have a hearing loss, some of the hearing loss, right? But if you speak a sound more than the threshold, if you speak loud, then these people can hear and they can understand also. But understanding of the sound gets affected in retrocochlear disease, eighth nerve disease. So, the eighth nerve is disease, then hearing will also get decreased, but the understanding also will get decreased, and therefore, the bearer of the person gets affected in that person. So, this is what I think you are trying to say. So, when I draw the ear like this, pinna, canal, tympanic membrane, middle ear with 3 ossicles. So, I draw 3 dots, inner ear which has a cochlea and the vestibule. From here, the 8th nerve carries the sound via the brain stem, which goes to the cortex, right? Now, no matter where the disease is, it will affect hearing. The patient cannot hear a low intensity sound. There is a certain threshold, and if you increase loud sound, if you speak loudly, the person will hear the sound. But disease of this part of the ear does not affect understanding of sound. That means a patient's hearing threshold has increased in this area with the external ear, middle ear, cochlea, in this area, cochlea also. Patient's hearing has decreased, and so if you can't hear, you can't understand. But if you speak in a sound which is louder than the threshold, which the patient can start hearing, once they start hearing, they can also understand what is being said. There is no problem with understanding, only the hearing is affected. Once the hearing is improved with the hearing aid or anything, then the understanding also improves, they can understand also. Whereas in this area, understanding gets affected. understanding words is affected along with hearing loss. So, along with the hearing loss, the patient's understanding also is affected. So, now if we start speaking in a louder voice, or if you give a hearing aid, they can hear the sound because you are speaking louder, they can hear. Or if you use a hearing aid, through the hearing aid they can hear the sound, but they cannot understand all the sounds. So, the sound gets affected, the understanding gets affected. So, this happens in a retrocochlear disease mainly. It is so in ENT we don't discuss brainstem and cortex because that is a domain of the neurosurgeons and neurologists. In ENT we don't deal with. From the ENT point of view, eighth nerve disease has this problem. Eighth nerve disease called retrocochlear disease. So, in a retrocochlear disease, BERA is abnormal. BERA is abnormal in retrocochlear disease, and in retrocochlear disease also the understanding of the word is affected. So, that is what Vignesh is trying to say when he is saying that history of child, they can hear the sound but does not understand the speech. And this is true for all retrocochlear diseases. This is true for all retrocochlear diseases. Right. So, I hope you understand this point. It might be. So, if there is a history, as he is saying, of any person, not only child, anybody who can hear but cannot understand, then this is most likely a eighth nerve disease. This is most likely a eighth nerve disease, and you can find out this with speech audiometry. What will help you find out? Speech audiometry will find out. So, the score will be low, discrimination will be low. When you do speech audiometry, you can find the discrimination, and the description of this patient will be very, very low. Okay. So, this is the meaning of this sentence. Now, talking about the BERA a little bit more, see, this is the same thing. I have drawn this diagram, auditory pathway, external ear, middle ear, cochlea, eighth nerve. I have removed the brainstem and the brain. The same thing I have written here. There is external ear, there is middle ear, there is cochlea, there is eighth nerve. This is your brainstem. And this is your cortex brain. So, this whole thing, the entire thing is called the auditory pathway. Right. Now, so in this area, disease only hearing affected, and in this area hearing and understanding affected. So, I am telling you what we have just discussed, the same thing I am repeating, right. Now, when you do BERA, BERA means brainstem evoked response audiometry. So, BERA is about brainstem. This part is the brainstem. So, BERA talks about the brainstem. So, when we do a BERA, we get a graph which is like this. BERA has many of these peaks which are numbered like peak. This is peak 1, peak 2, peak 3, peak 4, peak 5, 6 and 7. So, ideally a BERA graph will have 7 peaks. Out of the 7 peaks of the BERA graph, the most important peak is the 5th peak, and the 5th peak is produced by lateral lemniscus, and this is a very, very popular MCQ also. Who produces the 5th peak of the BERA? It is produced by lateral lemniscus. Now, for us the most important thing in a BERA is the latency between the 1st and the 5th peak of the BERA. Latency is time gap. How much time it takes for the sound to travel from the first peak to the fifth peak. This latency is normal in cochlear disease, and it is increased, which is abnormal, in retrocochlear disease. So, because auditory neuropathy is a retrocochlear disease, auditory neuropathy is a 8th nerve disease, a retrocochlear disease, so BERA will be increased or abnormal, not normal. So, in choice A this was written. And otoacoustic emission, it is normal or present in retrocochlear disease, and it is absent or abnormal in a cochlear disease. And in that choice A, it says OA is normal, that suggests it is a retrocochlear disease. So, in a retrocochlear disease, which is auditory neuropathy, both are matching in choice A. In choice A, OA is normal. So, in retrocochlear this is supposed to be true, and BERA is abnormal, and that is also supposed to be true in a retrocochlear disease. Right. Now, this is the chart telling you which are the investigations or findings of cochlear disease. These are the findings of cochlear disease, and these are the findings of retrocochlear disease. So, in a cochlear disease, BERA is normal, OA is absent, I just told you, and there are other things in the cochlear disease like recruitment will be there, and there will be short increment sensitivity index also will be a feature of cochlear disease. Whereas in a retrocochlear disease like auditory neuropathy, example auditory neuropathy, BERA will be increased latency, which is abnormal. So, abnormal BERA, and OA will be normal, and these two things were given in this question, so it becomes true. But along with that, other features of retrocochlear disease are like tone decay phenomena, there is a rollover curve, and low speech discrimination score. So, this is what Vignesh was talking about. The patient has a low discrimination, means they cannot understand the word that is being spoken. Discrimination is low, and to find this we have to do speech audiometry, as I told you already. Right. BERA and speech audiometries are two very different investigations. There is no relation. They are absolutely different kind of test. Absolutely different. There is nothing. BERA is not a type of speech audiometry. No, it is different. Not able to, Satyendra says, please tell first and the best screening test for newborn. For newborn child, this is OAE being done. This is how OA is done. This is the first and also the best screening for newborns. Right. OA is the first test that is done. There is no doubt about this, that this is the first test that is done for newborns, because it's a very simple type of a test. But when I say it is the best test for screening in newborn, now this might be a controversial sentence. You might argue that BERA is best, which is not a wrong sentence to say, because BERA gives better information as compared to OAE. So, there is no doubt that BERA gives you better information, but still in a newborn child we usually don't need all the information, That's why OA is still the best, because based on OA, we may or may not do BERA. BERA is never the first test done. So if something that you cannot do initially is not good for anything, so it's not good. So you can't say it's the best information. Yes, BERA gives better information, that is true, but still I can't call it a best investigation. So first as well as best is OAE, although BERA gives better information. Okay, and stapedial reflex is also absent in a retrocochlear disease. Sukuna says that is true. Stapedial reflex is also absent in a retrocochlear disease. Correct. So you can add here. You can add absent stapedial reflex. You can add that. So that's a correct statement. So best for neonate is OAE and best for neonate in ICU is BERA. Well, I will not dispute this sentence, Vignesh, that best for neonate is OAE, but best for neonate in ICU is BERA is not entirely true. The second sentence is not entirely true. You have to take this particular sentence with a pinch of salt. It depends on the cause of admission to ICU. It depends on the cause of admission to the ICU. If you suspect that the patient is admitted to ICU because of a disease that causes retrocochlear problem, then BERA is better. So when you say, and if you suspect that the patient has been admitted to ICU for disease that can affect the cochlea, then OA is better. You know where this sentence is coming from. If Vignesh is telling you that BERA is better for a neonate who has been admitted to ICU, that means you are assuming that the patient has been admitted to ICU because of meningitis. क्योंकि बुक्स में ये लिखा होता है, most of the books says a newborn child has meningitis, so he got admitted in the ICU, he or she got admitted in the ICU, and now before you discharge that person from the ICU, what is the investigation you would like to do? Then we like to do BERA because meningitis affects the cochlear nerve, the 8th nerve, and that BERA will pick up. It's a retrocochlear disease. But not all kids in the ICU are meningitis or diseases that affect the retrocochlea. If retrocochlea is not affected, BERA is not a good investigation. Then if cochlea is affected, like if somebody has what do you call it, jaundice, a child has a jaundice, then cochlea is affected more. 8th nerve can be affected, that is less affected. If the child has a low birth weight, cochlea is affected, low birth weight child, child who had hypoxia, cochlea can get affected. In these cases, BERA is not useful. So to assume that every child who is in an ICU, BERA is always better than OAE is not always true. But like I said, I'll repeat, this sentence is coming because it is given in books that most kids with meningitis, because question ऐसा बना हुआ है, एक question आया हुआ है पुराना, there was a question long back that a newborn child has meningitis, he was admitted to ICU, before discharging to check the hearing, what investigation will you do? BERA is the correct answer. But that is meningitis mentioned है उसमें, or because of that it is written in a lot of books also like this, that this sentence that is saying that a newborn child O is better, but child in ICU BERA is better, but it is not entirely true. I hope you get the whole gist about it. Okay, I hope I've been able to clarify if you have any doubts about this. But one thing you realize that this topic is very important, BERA, cochlea versus retrocochlea, and it's a very deep topic. You can keep on and on talking about this. I can talk about this topic almost, let's say 2-3 hours. It's so big topic. Yeah, so it is supposed to be central pathology, not always true. ICU patients are not always central pathology. So that's what we are assuming when we say that. So absolutely. Then we go to the next question, question number 7. A 30-year-old presented with hearing loss and ear discharge for few months. No other complaints. Systemic examination was normal and vitals are stable. The otoscopic finding is shown. Which of the following is not indicated in this patient? There is an image: modified radical mastoidectomy, myringoplasty, tympanoplasty, eardrops. So first of all, please answer this question. What is your answer? Based on that, we'll discuss. So it's an adult with hearing loss and discharge, and there's an image and the name of the procedures and treatment given, which is not indicated in this patient. I'm waiting for your answers. I can see 2 A's already. So there are 3 A's. Sukunai Singh B, there are 4 B's, not A, B. Sukunai Singh B, Raji Singh B, Soumya Jhai Singh B, Som Subrai Singh B, Meringoplasty. So what is the diagnosis, guys? Diagnosis. And what is the finding? Describe the finding and give me the diagnosis first. Then we'll come to the answer. Because unless you, here the image is very important. In this particular case, the image is very important because that will give you the diagnosis. So I want you to write the finding and make a diagnosis. I can see people saying CSOM. So you have to tell me what type of CSOM this is, safe or unsafe. Is it safe CSOM? Is it unsafe CSOM? What is it? Now, this is a atic perforation. An atic perforation is pars flaccida perforation. And pars flaccida perforation is seen in unsafe CSOM. So this is diagnostic of, this is a patient of unsafe CSOM. And in unsafe CSOM, meringoplasty is contraindicated. So in unsafe CSOM, meringoplasty is contraindicated. So yes, B is the correct answer. So these are the features of unsafe CSOM. Unsafe CSOM has a less or scanty discharge. It has a red polyp in the ear. It has a foul smell in the discharge. There are red granulations in the ear. Retraction pocket and colostoma may be there. Retraction pocket colostoma. There are more complication and either atic perforation or marginal perforation, and the treatment of choice is modified radical mastodectomy. These are the features of unsafe CSOM. Now, so when we say these are the features of unsafe CSOM, doesn't mean every patient of unsafe will have all of them. So some features in some people, in some unsafe, some may have this one, some may have that one, and depends on which of the features is given, any of them will tell you whether it is less discharge, or if there is a red polyp in the ear, that is diagnostic. If there is a foul smelling discharge, but if there is no foul smell in the discharge, doesn't mean it cannot be unsafe CSOM. If there is no smell but there is a red granulation, it is unsafe. If there is no smell but there is a atic perforation, it is unsafe. So in this particular image that we have seen, in this particular question that we have discussed, also, although in the smell it is not mentioned that is foul smelling, so that does not mean it cannot be unsafe CSOM. It can be if it has any other feature. In this particular, the image is telling you because it has atic perforation, that's why it is unsafe CSOM. Okay, and in unsafe CSOM, there is a atic perforation. So you want to see the difference between retraction pocket. Aditi, let me show you the image of a retraction pocket and retraction of the atic perforation. Let me show you the difference between the two. If you look at these two images, they are both some problem in the pars flaccida. This is pars flaccida. This is pars flaccida, and this is also pars flaccida. They have something in the pars flaccida. The first one is a perforation. This is a perforation of the pars flaccida, and this is a retraction pocket of pars flaccida. So now look for yourself, and you can easily now differentiate between a retraction pocket versus a perforation. Retraction pocket, because the, as it says, it's a pocket. There is a pocket, there is no perforation, and there is no colostoma. So because there is no colostoma yet, there is no destruction, because colostoma is the one that causes destruction. Retraction pocket will form colostoma, but it is not yet. So retraction pocket, if you look, the second image is very neat and clean, and you can see a pocket is formed. Whereas if there is a colostoma in this area, it will cause the destruction, and this is, as it will look like the first image, which is a perforation. It's not a neat and clean thing. You can see a lot of damage is there. This is a perforation due to colostoma, but both are feature of unsafe CSOM. Both are features of unsafe CSOM. Whether it is retraction pocket or perforation in the pars flaccida, both are retraction pocket. Okay, I hope that this is clear. Now, in unsafe CSOM, for myringoplasty, let me talk about something about myringoplasty. I am trying to answer this question that by Ryan, that why is myringoplasty contraindicated in unsafe CSOM. Now, what is myringoplasty surgery? In myringoplasty, we place a temporalis fascia graft in tympanic membrane. We place a temporalis fascia graft in tympanic membrane, right? Now, for this to be successful, the health of annulus should be very good, because annulus, you all know, the boundary of the tympanic membrane is called annulus. So if this is your tympanic membrane and we do the handle of Meniers and all this, so this boundary is called the annulus. For the graft to be successful, to take up, as we call it, the right word is, if the graft has to take up, which means it has to be successful, then the health of the annulus is very, very important. And in unsafe CSOM, the annulus is not healthy, it is damaged. See, this annulus is affected in marginal perforation, annulus is affected, the boundary is affected, and that's why if the annulus is affected, then the graft will simply not take up. Okay, that's why meningoplasty cannot be done in unsafe CSOM because the annulus is affected. And in meningoplasty, we place a graft, temporary place a graft on the tympanic membrane and nothing else is done. And nothing else is done in middle ear. This is a very typical of meningoplasty. The definition of meningoplasty is that you are only repairing the tympanic membrane with a graft, preferably a temporary fascia graft. If along with that, if you are doing something in the middle ear also, then this surgery is not called meningoplasty. It is called tympanoplasty. Tympanoplasty. So that's why in unsafe CSOM, there is always a disease, something in the middle ear. Unsafe has something in the middle ear always. So if you don't remove that disease in the middle ear in unsafe CSOM and only repair the graft, then the surgery is not successful because you are not treated the patient, you have only repaired the tympanic membrane. So it's never right. It's like कि सब कुछ खराब है अंदर, आपने एक पर्दा डाल के सब कुछ छुपा दिया है, but that is not good. जो खराबी है, whatever is the problem there, you have to remove the disease. The moment you start removing any disease of the middle ear, the surgery is not called meningoplasty. The name changes and becomes tympanoplasty. So here it's a technical problem also. Technical nomenclature is a issue here. So where you call it meningoplasty, where you call it tympanoplasty. Do you know meningoplasty is also called type 1 tympanoplasty. If you read your books, if you read your notes, it is written everywhere that meningoplasty is also called type 1 tympanoplasty. आपने शायद पढ़ा भी होगा. Also I in my class notes write that, right? But this sentence is not 100% correct. They are not exactly the same thing. There is a very minor difference between the two things. What is that minor difference between the two things? Let me explain, and that will answer your question also with the help of a similar diagram. So when I draw the ear and canal and middle ear, this is the middle ear, okay, and this is the tympanic membrane. This is the tympanic membrane, and the tympanic membrane has a perforation like this, but no disease in middle ear. No disease in the middle ear. So what will you do? You will just cover this with a graft. You place a graft here. This is a graft. Because you did not have to do anything in the middle ear, this surgery is called meningoplasty surgery. Meningoplasty surgery. Because you have to not do anything. Now, when you are not sure, question mark, you are not sure of middle ear disease, है कि नहीं है, you can only see this, but you are not sure middle ear disease है कि नहीं है. So before placing the graft, you will look into middle ear. So what you do, before putting graft, if you check middle ear, आपने चेक कर लिया है, अब सर्जरी इज नॉट कॉल्ड meningoplasty, but found no disease in middle ear. So you found there is no disease in the middle ear, but you at least checked. So only placed graft on tympanic membrane. Again you ended up doing the same thing. The difference between the two, now it is called tympanoplasty. This becomes tympanoplasty. मतलब मेरिंगोप्लास्टी और टिम्पेनोप्लास्टी में डिफरेंस इतना कि आपने मिडलियर में देखा भी नहीं और कुछ किया नहीं. That's why in unsafe CSOM you cannot do this. You cannot not check the middle ear. You have to check the middle ear because unsafe has a lot of problems in the middle ear. So you cannot do meningoplastry ki aap gaye and just place a graft on the membrane and you came out. No, you can't do that. You have to check the middle ear. You may find disease inside, you may not find, but the moment you check in, it is not meningoplasty anymore. Okay, so I think that should be that should rule out clearly all your doubts if there is any. Okay. Now there are two ways of placing the graph. If you place the graph here, this graph is inside annulus and this is called inlay technique. So if you place the graph inside the tympanic membrane, it is called inlay technique. And if you place a graph outside the tympanic membrane, suppose you place a graph here. Now this graph is outside the annulus. This becomes onlay technique. So this is the only difference between inlay and onlay technique कि ग्राफ को आपने अंदर की तरफ रखा कि बाहर की तरफ. एनुलस के अंदर चले गए तो इनले, इफ यू आर आउटसाइड द एनुलस इट इज ऑनले. So Som Subra, this is your answer. I think it should clarify. Inlay is also called underlay, onlay is called overlay. Onlay is called overlay, inlay is called underlay. So Vignesh has summarized very nicely that checking the middle ear health will make it tympanoplasty. Not checking the middle ear health, just putting the graph is meringoplasty. Absolutely spot on. Good. So this should be able to clarify a lot of your doubts, I'm sure. Next question. A young man met with an accident leading to a loss of hearing in the right ear. On otoscopic examination, the tympanic membrane was intact. Pure tone audiometry shows A-B gap of 54 decibel on the right ear with normal cochlear reserve. Which of the following will be a probable tympanometry finding? A, S, A, D, B or C? So what do you understand from this question? Please explain the question first. So I can see lot of B, Som Subra is saying B, Aditi is saying B, Ryan is saying B. So this is a trauma leading to hearing loss. Now trauma leading to hearing loss with intact tympanic membrane. So that means the trauma has affected either middle ear or inner ear. If middle is affected, again you have hearing loss. If it is inner ear, again it is hearing loss. But inner ear will have normal cochlear reserve. So if cochlear reserve is normal, it is not inner ear. So it is middle ear disease, middle ear trauma. In middle ear trauma, you have ossicular damage with intact tympanic membrane. And this is seen in this situation, you get a AD type of tympanogram. And in this condition, the hearing loss AB gap is 54 to 60 decibel gap. So if you have a gap of 54 to 60, then again this is diagnostic of ossicular chain damage with tympanic membrane. So in this question, it is telling you there is AB gap, cochlear reserve is normal, and tympanic membrane is intact. So these three things are telling us that it is ossicular chain damage with perforated membrane. Now if I ask you that there is one situation, ossicular damage with intact tympanic membrane, and situation number 2, ossicular damage with perforated tympanic membrane, which one has more hearing loss, which is better hearing? In one case, ossicular chain damage, the membrane is normal. In the second case, both are damaged, ossicles are damaged, membrane is also perforated. So which one is better, or which one has more hearing loss? So first one has more loss of 54 to 60 as we discussed. Second one is better, as you are rightly saying, less loss of 38 to 40. Right. So this question was about this, and in this patient you will get, in this one you will get AD tympanogram, AD type tympanogram, which is our question. So everybody is saying what we just discussed correctly, so that's good. So talking about tympanogram, these are the 5 types of tympanograms possible. I'm sure everybody knows this, very regular thing, but just in case if does not know, A type is normal ear, AS is otosclerosis, AD is damage of the ossicle, this is what we discussed, B in serous media, and C, which is negative, is station tube block. Out of the 5, the most commonly asked is AS, very commonly asked. B is also quite common. These two are very commonly asked, but I have asked you this one, which is relatively less important from the exam point of view. But the idea was that you get the concept of ossicular chain damage with intact membrane. That was more important. But we shall go to the next question. A 24-year-old presented with hearing loss in the right ear, Mbbs is lateralized to the right ear. Which of the following is possibility? Meniers disease in the left ear, AOM in the right ear, presbyacusis in the right ear, otosclerosis in the left ear. So which one do you think is a possibility in this patient? So I am waiting for more answers. Let's see. So I can see 2 people answering so far. Som Subra is saying B, and Somit Gangopadhyay is also saying B. Satyendra is also saying B. 3 people have answered B, and Aditi Goyal is also saying B. Let us see how does Soumya Jha is saying B. So how do you answer this question? For those who don't know, because B is the correct answer. Suppose this is the right ear and this is the left ear. Patient is telling you it is hearing loss in the right ear. That means this is normal, because if the patient is only complaining of hearing loss in the right ear, obviously that one is normal. Now this could be either CHL or SNHL. We don't know what type of hearing loss are. 2 types, either CHL or SNHL. Now the finding of Mbbs is given. Mbbs in CHL goes to the same site, it will come to this side. Mbbs in SNHL will go to this side. And the second line of the question says Mbbs is lateralized to the right ear. That means not this one. So this is not possible. That means a disease which is causing CHL in the right ear has to be the correct answer. Left ear is normal. Now before I start writing all these things, the moment you read this question and it says the patient has hearing loss in the right ear, obviously there is no complaint of the left ear, so there can be no disease in the left ear. So this cannot be answer. This has to be ruled out, and this cannot be answer. This is gone, because hearing loss right ear में है. So choices having right ear problems can only be the correct answer. So A and D is straightway ruled out because they are telling you disease of the left ear, and left ear is not mentioned, so it is normal. So it has to be one of these two. Now this causes CHL, and presbyacusis always causes SNHL, because presbyacusis is a inner ear disease. AOM is a middle ear disease. So, and from here we understand that it must be right ear CHL, and so right ear we have AOM, and so B becomes the correct answer. AOM in the right ear. That's how you do this question. So the moment they are telling you hearing loss in one ear, not the other, जो भी choice में other ear के बारे में disease लिखा हुआ, that becomes not correct. So you just strike them off. So if you rule out of 4 2 straightway, then it becomes even easier to answer the question. So this is how you proceed in this kind of questions. It is easy question, I think, not a problem. Should not be a problem. Next question. An 8-year-old child presented with breathing with open mouth and hearing loss. The image is shown. So which of the maybe finding in this child? Deviated nasal septum, high arched palate, crowding of the upper teeth, positive crescent sign. So similar question was asked last year. Last year this similar question was asked in INI set. This question was asked in INI set. So I think most of you can answer this very easily. It's a very simple question. So what is the diagnosis? Diagnosis, we all know adenoid faces due to adenoid hypertrophy. These are mouth breathers. We call them mouth breathers also. That's why if you look at the image, the mouth is open. The patient has to keep the mouth open, and these are the 5 features of adenoid faces: high arched palate, prominent upper teeth and crowded upper teeth, pinched nose or collapsed ala, hypoplastic maxilla, dull expression. So out of this, only first one is given in the choices. So in the choice, only high arched palate out of the 5 is given. Rest of the crowding of the, not the upper lower teeth. In this patient, it is upper teeth. And there is no DNS. DNS has nothing to do with adenoid faces. And positive crescent sign is seen in AC polyp, antroconal polyp. Positive crescent sign is seen in antroconal polyp, and this has nothing to do with antroconal polyp. In adenoid, there is no crescent sign. Right. So these are the 5 features of adenoid faces. Now, one of the ways of remembering these 5 features are that the first 2 features are present in the mouth. Both are features of the mouth. Palate is a part of the mouth, upper teeth are the part of the mouth. The next 2 are features of nose. So that's how you remember 2 changes in the mouth, 2 changes in the nose, and dull expression is also called long face. This is an overall look on the face. Overall look. So if you divide like that, there are two changes in the mouth, two in the nose, and there is an overall look on the face, it becomes easier to remember, right? Now let me explain, since somebody is asked to explain the crescent sign, and before I explain the crescent sign, let me explain why these changes happen, so that it will be easier. Once you know why they happen, logic, then it is easier to remember this, and then I will go on to explain the crescent sign also. Now when I draw the face like this, let's say, and this is your pharynx. Now the skull base is like this, curved base of the skull, and that is why when I breathe, the air that enters in goes in like this. This is how the air that we breathe in from the nose goes. So this is almost like a parabolic curve, and this is a very smooth lamellar flow. So this is a lamellar flow. But if the patient starts breathing from the mouth, then the air goes straight like this, because the palate is straight and there is a sudden turn. So there is no parabolic curve, and this is a turbulent flow. So this is the main change that happens between lamellar flow and turbulent flow, breathing from the mouth and breathing from the nose. And turbulent flow is not a good thing for the brain. So when you have a turbulent flow, the brain thinks that I must make it same as lamellar flow. So what it does, the palate becomes high arched like this, like the skull base, and now the flow becomes like this, matching. So this is what the brain is trying to do, compensate and try to make the flow. Now it is no more turbulent, it becomes a lamellar flow. So basically by making the palate high arched, the brain is trying to correct the flow, the shape of the flow. Normally, second point is, normally there is an opening in the nostril, and because there is an opening of the nostril, this one, the air has to go in without any effort. So the brain is trying to make an opening here also in the mouth. So how does it create an opening in the mouth? It pushes the upper teeth and the upper lip forward. Your lip comes like this, upper lip, and lower lip remains behind. So between the two, a gap gets created, permanent gap gets created like the nostril, and now the patient will not have to make effort, because there is a gap here. By pushing the upper teeth, crowding of the upper teeth, making it prominent, the upper teeth gets pushed backward, lower teeth remains behind. So there is a gap between the two, and through that gap is like a nostril. So you can say that the brain is trying to make the mouth like the nose, nose ki tarah ban raha, and there are two changes, that is making the mouth like the nose. And because the nose is not being blocked, being used, because the nose is not being used, that's why the nose tends to close. So there is a pinched nose. When you pinch the nose will close. So nose tends to close, and because the maxilla is not used, the maxilla also tends to close, become small. So mouth is trying to become like the nose, and nose is trying to close, and the net effect is the adenoid faces. So that is the easiest way of remembering the adenoid faces that we discussed. Now I'll use the same diagram to talk about crescent sign. Crescent sign is to differentiate AC polyp and JNA, juvenile nasopharyngeal angiofibroma. This is the basic use of crescent sign, because both are seen in small child, in a child with mass in posterior nose, which is quena. So both have a mass in the quena. AC polyp is in the quena, antrochoanal polyp. See, the name of the polyp is antrochoanal polyp. And juvenile angiofibroma is seen in sphenopalatine foramen, and sphenopalatine foramen is also in the quena. So both are growths, both are in the quena, both are seen in children. So sometimes you get confused. Now, sphenopalatine foramen is somewhere here. That's why if there is a tumor, angiofibroma, the angiofibroma is somewhere here. This is JNA. Because of the growth here, the air that we breathe does not, the flow of the air does not change. The air goes like normally like this. So there is no flow in the air, change of the airway, right? So if you take an X-ray from the side, lateral view, you will see the normal airway, and above the normal airway there is a growth. But AC polyp comes from the maxilla, antrochoanal polyp. Antrum is the name of the maxilla. So from the maxilla the polyp comes in the nose, and the polyp grows from the maxilla towards the nasopharynx. So this is your AC polyp. So because of this AC polyp, the air cannot go like this. Air cannot go like this through the normal route. So the air goes from here. So the air column will be seen between the growth and the skull base. You see the air column here. This is the air column that you see between the growth and the skull base. You can see air column which has shifted up, and this shape of the air column is crescentic. This shape is called crescent shape. This is the crescent shape, like a half moon shape is a crescent shape, and this is called crescent sign. So between the growth and the skull base, if you see a crescent shape, air shadow, that is a crescent sign. It is seen in AC polyp, but in an angiofibroma you will not see any such thing, because the air is flowing through the roughly a normal area. So this is the difference between the two. So Aditi Goyal has said, draft of air seen on the lateral X-ray on endocrine polyp as seen in space between the posterior wall and the polyp, not the posterior wall, superior wall. That is a correction. Otherwise, you are correct, Aditi. Superior wall and the polyp, not the posterior wall so much. But in not adenoid, JNA, the mass arises from the posterior wall and there is no space. So it is about JNA and AC polyp. Okay, it is not about angiofibroma. So slight correction, but by and large, Aditi is correct. I hope that clarifies those who wanted to know crescent sign. Okay, next is a very simple question. I think most of you should be able to identify, answer this question. A patient with episodic vertigo for the past few months has undergone the procedure shown in the image. Which of the following procedure is being carried out? So it's a very simple, straightforward question. Tympanoplasty, grommet insertion, Silverstein microwick, and Meniers device. So I think this is a very straightforward, very simple question. Everybody should be able to answer this question. So I'm waiting for your answers, guys. Is this tympanoplasty? Is this grommet insertion? Is this Silverstein microwick? Is this Meniers device? So Raj is saying C, Aditi Goyal is saying C. Yes, this is C, Silverstein microwick. Also, this tube that you see is called microweak microcatheter. This is called microweak microcatheter, and it is produced by many companies. So based on the name of the company, it can also be called silver stain because that is based on the company, and it has either gentamicin or streptomycin inside it, mostly gentamicin, and the tip is placed at the round window. Now this is the most important point about this particular procedure. Where is the tip of this microweak microcatheter placed? At the round window, and so through the round window gentamicin enters cochlea via a procedure called endocytosis. The procedure that is used by which the genta enters the cochlea is called not cochlea, labyrinth, inner ear. The gentamicin enters the inner ear via a process called endocytosis, and gentamicin or streptomycin, being ototoxic drugs, they damage vestibule, and this will relieve vertigo. So once the vestibule is gone, the vertigo is gone, and that's why this procedure is either called medical vestibulectomy because the medicine is damaging the vestibule, so it's called medical vestibulectomy, as you can see the way I have explained to it. Also called intratympanic gentamicin, because through this tube the gentamicin is placed in the middle ear. The tube is in the middle ear, so gentamicin is in the middle ear, so intratympanic gentamicin, and it is mainly used for Meniers disease, but it is also used for BPPV. So it can be used for Meniers, also for BPPV sometimes. It can be useful or beneficial in both the conditions, right? Now Meniers device looks very different. This is how this one looks like that we discussed, and this is how the Meniers device looks like. So Meniers device is a very different kind of a gadget, you can say, and this is also used to treat Meniers disease, and as it is written here, it produces low intensity pulsations. And grommet we all know, I don't have to show grommet, but still I will show you how a grommet looks like. This is how the grommet looks like. I think this is a very common image, everybody knows about grommet. I don't even have to show you this. So now image, if there is any confusion in the image, then you know how a Meniers device looks like, how a grommet looks like. And tympanoplasty, there is no device used. Tympanoplasty is simple surgery without any device, so there is nothing in tympanoplasty. Now Meniers disease treatment is a very important question, very commonly asked in the exam. So what are the options for Meniers disease treatment? We have 5 options. We give some advice. We have drugs, we have device, and we have exercise, and surgery. This procedure that we discussed is a type of surgery. There are 2 advice we give: decrease the intake of salt and water, and stop the intake of nicotine and caffeine. So no nicotine, no caffeine. The most important drug besides anti-vertigo, antiemetic is a beta-histine. Beta-histine is the most popular drug. Steroids are very useful, and anti-vertigo with antiemetics can be used. The device is what I have shown you, that Meniers device. Meniers device. The exercise called Cawthorne-Cooksie exercise. The name of the exercise that is done for Meniers disease is called Cawthorne-Cooksie exercise. And many procedure, one of the procedure is this one, intratympanic gentamicin that we discussed. The image is intratympanic genta is the best and the latest treatment for Meniers disease. Right. So these are the points about Meniers disease treatment. Now I have deliberately written this line because I know there is a MCQ going around. A lot of people have asked me that treatment of choice for intractable Meniers. This is a question in some MCQs. I don't know, people are asking me, and the answer given is labyrinthectomy. And this is a wrong answer. Or you can say it's an old answer. Let's not call it wrong, it's an old answer. Okay, labyrinthectomy is not indicated for any common disease. Not indicated now. Almost for any disease except tumors. Carcinomas you can do, but inner ear carcinomas are extremely rare. I don't know that in my 25 years of practice, I've not even come across anybody who has seen a carcinoma of the inner ear. It's so rare. So labyrinthectomy is hardly done. It used to be done in the past. We don't do it anymore. This is a vestibulectomy. Remember, I wrote here. This is a type of vestibulectomy, not labyrinthectomy. So if you read this question and the answer given is labyrinthectomy, take that answer with a pinch of salt. It's not a wrong answer. I'm not telling you it's a wrong answer, but it's not the correct answer either. It's an old answer. The answer, it has changed many years back, because labyrinthectomy in today's time, labyrinthectomy is like a crime. It's like a crime. Right. Now, how does Meniers device help? Now, that's a very complex question to answer. How does Meniers device help? Let me try to help you with that. Try to answer this question with the help of this image diagram. Now, in Meniers disease, what happens? In Meniers disease, this is called endolymphatic hydrops. So, this blue thing is the hydrops, normal endolymph. The blue thing is the endolymph, and it is present in the inner ear, as you can see, and this is a normal image. In Meniers disease, the quantity of endolymph increases and the membranous sac increases in size, and it becomes like this. So, the increase of the size has happened because there is more fluid. That fluid is accumulated only in this area of the inner ear, that extra fluid. It has not gone here. This area has not received extra fluid. There is no extra fluid in this area also of the cochlea. Only this small area of the inner ear has little extra fluid, and that is causing the problem of Meniers disease. Now, if you cannot remove this extra fluid, what you can do is, if you can redistribute this fluid in the entire inner ear, if you redistribute this fluid, you push some fluid in this area, you push some fluid in here, you push some fluid in these canals, then the amount of fluid here will reduce. If the amount of fluid here reduces, the symptoms will disappear or at least improve. So, Meniers device is doing exactly the same thing. It is redistributing the fluid in the entire inner ear so that there is no accumulation of that small fluid, extra fluid in the small area. So, that's what the device does. If you remember the image, the device is put in the canal, and I told you it is producing low intensity pulsations. So it is like pushing the oval window. This oval window, it is pushing inside, thoda thoda, halka halka. So when you are pushing this fluid, the fluid is pushing itself in other area and it is redistributing in the other part of the labyrinth also, and over a period of time this fluid is gone. Some of it is gone here, some of it is gone here, some of it gone here. So this area becomes small again, and if this area becomes small, the symptoms disappear or at least reduce. So that's how Meniers device help. So I don't know whether you have been able to understand. So basically it is that small fluid, extra fluid which is accumulated in a small area is spread in a larger area by this device, so that small area with extra fluid has improved and the symptoms will improve. Does it make any sense? I hope so. Ryan, बताना समझ में आया, कुछ फर्क पड़ा or not? But it's not important actually. So even if you don't understand, nobody is going to ask you how it helps. नाम जरूरी है, disease का नाम जरूरी है. That's all you have to know. But in the meanwhile, we will go to the next question. Question number 12. Image showing injections at the medial canthus. As you can see, image showing injection of the medial canthus. So this is a question from 2021. This was asked in NEET PG 2021. Exactly the same question with same choices. So what is your answer? Nasolacrimal duct probing, anti-ethmoidal nerve block, median nerve block, or post-ethmoidal nerve block. And I can hear Soumya Jha saying B, Supuna saying B, Satyendra saying B, and B is the correct answer. Like in nasolacrimal duct, no injection. No injection, only probing. Only probe is used. And the direction of the nasolacrimal duct goes like this. Median neurectomy, median nerve block has no indication. We don't block the median nerve. Median neurectomy is done. Median neurectomy is done in vasomotor rhinitis, but there is no indication of median nerve block. And post-ethmoidal nerve block usually not done because it does not help. Post-ethmoidal nerve is usually not done because it is usually not helped. Right. Now, whenever we block the nerve, any nerve that we block anywhere in the body, usually only sensory nerves are blocked. Isn't it? Because you want to block the sense of touch and pain. When you are doing any procedure anywhere in the body, when you are doing some procedure, the patient can feel the touch of the instrument, that causes anxiety and pain. So we want to block these two things only, otherwise it is nothing else. Median nerve does not have the touch or the pain fibers. Median nerve is a purely sensory motor fiber, special motor, parasympathetic and sympathetic fiber. So blocking the median nerve is not going to help in any way, but we cut it in a vasomotor rhinitis, like I said. Ryan is saying, is in anterior nerve, anterior ethmoidal nerve blockade 1 centimeter above the canthus and not in the question it is medial canthus. No, I think you are mistaking, Ryan. In the median nerve blockade, we do at the canthus, but we go 1 centimeter deep. Deep we go, 1.2 centimeter to be more precise. But let me explain all this. See, when I draw the coronal section of the nose, the coronal section of the nose is usually drawn like this. This is your nasal cavity, let's say, and this nose is divided into 2 equal halves by the septum in the midline. On both sides we have maxilla. So let me draw the maxilla like this. Let's say this is the maxilla, and we all know sitting on the maxilla is the orbit, and let's say orbit is like this. This is the orbit. Now in the orbit there is a nasociliary nerve. There is a nerve here, let's say like this, nasociliary nerve, and this nerve sends 2 branches to the nose. So one branch we can draw like this, one branch we can draw like this. These 2 branches then enter the nose and go down to supply the nasal cavity like this. So this is a very simplified diagram trying to show how this nasociliary nerve which is a branch of V1, ophthalmic division of first of trigeminal, and let us assume that this is the anterior ethmoidal nerve and this is the posterior ethmoidal nerve. Anterior ethmoidal nerve lies 1.2 centimeter deep to the skin of this area, or you can say lacrimal bone, lacrimal crest. This bone that you see is a lacrimal crest. 1.2 centimeter deep is the anterior ethmoidal nerve, and this lies 2.4 centimeter deep to the same area. Right. Now we are not interested in blocking this nerve. We are not interested because it's insignificant nerve. It supplies a very small part of the nose, so you don't have to block. So we are interested in blocking this nerve. So what you do is, if you inject in this area, which is near the canthus area, and go 1.2 centimeter deep and inject your xylocan, which is 0.5 ml xylocan is injected. The xylocan occupies this space, right? And so this xylocan is going to block this nerve as well as this nerve. They both gets blocked at the same time always, because one is a mother nerve, one is a daughter branching. So if you inject in that area, both this, the main branch and the main nerve and the branch both gets blocked, right? So it does not matter that the net result is the same. That's why whether it is medial canthus you are injecting, 1 centimeter below that, 1 centimeter above that, it does not matter, because the drug is going to occupy a lot of space, and in that diameter, in this area, everything gets blocked in this area. So that question, that point that you are saying we should be at the canthus or 1 centimeter below or above is not important. What is important is the depth. This is important, how deep you go from the crest, lacrimal crest. That's the main thing. So I think that's why sometimes you get confused. Depth you feel up, कई बार register करने में problem हो जाती है. Now the second thing is, now if I show you this image and ask you which nerve is being blocked, then, and I use the word medial canthus or 1 centimeter above the medial canthus, both are okay. Now both are correct answers. If anterethmoidal nerve is given, that is a correct answer. If anterethmoidal is not given, nasociliary is given, that is also correct answer. For both this nerve blockade, the procedure is exactly the same. Some books will call it anterethmoidal nerve, some will say nasociliary nerve, but it's the same thing. At the end of the day, there is no difference actually in the procedure. In the procedure, there is no difference. Okay, I hope this will clarify your doubts that you are trying to raise. right? And this is the image trying to show you. Look at the second image, this one. Now this is your trigeminal nerve, fifth nerve, and this is the first division of trigeminal, ophthalmic division. This is your second division, maxillary, and this is your third division, mandibular. Ophthalmic goes in the orbit to the superior orbital fissure, and just before entering the superior orbital fissure, which is somewhere here, it divides into three main branches, and this branch is the nasociliary branch. This is the nasociliary branch, right? And this branch sends two branches into the orbit. Can you see these two branches entering a foramina? Those two foramina are, one is the anti-ethmoidal foramen, one is the post-ethmoidal foramen. When these branches enter from here, the nerve is entering the nose. This is also entering the nose. This is also entering the nose. This is your nasociliary nerve, and this is the branch of the nerve. So when you go from the canthus 1.2 centimeter deep, 1.2 centimeter deep, and you inject the xylocaine here, now tell me, is this branch not getting blocked? And is this branch not getting blocked at the same time? Because you can't be precise. 1 millimeter का precision तो होगा नहीं कि सिर्फ 1 millimeter you can inject and it will not go beyond that. You can't be that precise, especially when you cannot see that area. It is just injecting something. So obviously a xylocaine is going to occupy all this space, and if your xylocaine is occupying this much of space, it will block this branch and also this branch. Both are getting blocked. So whether you say it is blocking the nasociliary nerve or you are going to say that it is blocking the anti-ethmoidal nerve, is the same thing. But this branch cannot get blocked because this is quite far off. If you inject xylocaine here, now this branch is not affected, which is post-ethmoidal nerve, and we don't want to block the post-ethmoidal nerve. It is useless blocking that. I hope this will clarify any doubt that you had, right? And this is showing you, this is the anti-ethmoidal nerve coming in the nose. From that foramen, the nerve comes in the nose like this to supply. So you block this nerve and your job is done. So these are some of the images trying to show you whatever you want to see. In the meanwhile, we'll go to next question. Ryan is asking if both nasociliary and anti-ethmoidal nerve are present in the options, which is a better answer. In the exam, you will never get a question of this type with both in the choices. Your examiner is not a fool. He knows when he's preparing the question. MCQ में हो सकता है. You might read MCQs because a lot of MCQs are prepared by anybody. आजकल कोई भी बैठ के किताब लिख रहा है, कोई भी बैठ के MCQs बना रहा है. They are not specialists of the subject. If I start making MCQs on ophthalmology or radiology, obviously I'm going to make mistakes. So if you read MCQ book prepared by a specialist, you will not find both the choices in the same question. होगा नहीं. So that question does not arise. Okay. If you read MCQs prepared by a non-specialist or MBBS guy जो MBBS किया वो question बना के पेल रहा है, then of course you might get such questions, such mistakes. That's why the moral is, the takeaway is, always read books, always prepare MCQs, always attend lectures given by the specialist of the subjects only. Don't attend lectures, read books and MCQs by non-specialists. These are the kind of mistakes people make when they don't know the subjects properly. So my submission is that don't read books, don't attend lectures by non-specialists. Okay. So question number 13. A 46-year-old came with a complaint of facial palsy. Please make a correction here. Facial palsy. Okay. On examination, it was found lower motor palsy is written here clearly. So ऊपर वाला printing mistake था. On further examination, there is no radiological or clinical finding. How will you treat this patient? This is a very simple, straightforward question. I think everybody can answer this without any problem. If you can't answer this question, problem hai. So what is the answer? There is a facial palsy, lower motor neuron types. So how do you treat? Without any findings. So without any findings, that means this is idiopathic. And idiopathic facial nerve palsy is also called Bell's palsy. And how do you treat Bell's palsy? Even non-medicos knows this answer. Such a simple question. Yes, steroid with acyclovir for 2 to 3 weeks is the first thing that you do. So Soumit Gangopadhyay, Sukuna, Aditi Goyal, Satyendu, absolutely spot on, correct. Now Bell's palsy, idiopathic facial nerve palsy, this is the flow chart that you should remember. This is the flow chart showing you how you proceed in a patient of Bell's palsy. So like we discussed, the first thing that we do is give steroid with acyclovir for 2 to 3 weeks, and usually it improves the situation. But if there is no response, then we do what is called electroneuronography should be done. Electroneuronography is a type of nerve stimulation test. Now nerve stimulation tests are 4 types. Some books says 5 types, some say 4 types. Out of those 4 or 5, whichever you want to believe, this is the best type of nerve stimulation test. And so we always do this because this is most helpful. The other name for this test is evoked myelography. Evoked myelography is the other name for this test, but we don't use this word evoked myelography ever, just in case. Now what does this nerve stimulation test does, electroneuronography? It grades the palsy into 5 grades, grade 1, 2, 3, 4, 5, depending on the severity of the damage, and further treatment depends on your grades. Is it grade 1, 2 or 3 or 4 or 5? In grade 1, 2 and 3, 1, 2 and 3, we continue steroid, because if it is grade 1, 2 and 3, which is a less severe trauma, the chances of recovery is more than 90%. If the chances of recovery is so high, 90%, then we don't want to change our treatment. We continue steroid and acyclovir. And but if it is grade 4 or 5, if it is grade 4 or 5, which is more severe, then we have to do one of the 3 surgeries. Surgery has to be done, and the name of the surgeries is given. We may have to do decompression of the facial nerve, which is most commonly done. Sometimes you have to do end-to-end anastomosis. Sometimes you have to place a graft there. Grafting has to be there, right? So this is the treatment for Bell's palsy in a nutshell, because like this question was, what is the treatment for Bell's palsy basically, but they ask you that in a Bell's palsy patient you have given steroid and acyclovir for 2-3 weeks, there is no response, what should you do next? They've asked this question in the past, what is the next thing? Then the answer comes from here. So that's why this slide is very important. Now 2 additional points. Acyclovir in a Bell's palsy is added only when the patient comes in the first 72 hours of palsy. Palsy होने के within 72 hours, which is 3 days. If the patient comes within 72 hours of palsy, then only acyclovir is useful. If the patient comes after 72 hours of palsy, he comes to you and tells me 5 दिन पहले हुआ था, but I was busy, I could not come. Today I am coming. So I had an exam, so I could not come. After the exam, yesterday exam was over, today I am coming. 5 days over, then no acyclovir, only steroid then. Okay. So acyclovir is useful only in the first 24 hours, and electroneuronography is done within 24 hours to 14 days. Within 2 days to 14 days of palsy. So electroneuronography is not done on the first day and not after 14 days. So this 2 days can be 3 days in some book, but it is not immediately. So if the patient does have palsy, if you try to do electroneuronography, it's not going to help. After 14 days if you do, it is not going to help. So within 2 and 14 days if you do, it is going to give you the best result, best information. Otherwise it is not going to be very, very useful. So these are the additional points about Bell's palsy. But please read the treatment of Bell's palsy. There is more, there is more thing in Bell's palsy. Please read that from your notes properly, because there are a lot of questions from here. But we'll go to the next question, question number 14. A child with history of pain in the throat with hoarseness of voice with high grade fever and toxic look is present with clinical condition as is shown. Identify the lesion. So patient has a sore throat, severe, and there is hoarseness of voice and there is high grade fever with toxic look, and the image is shown. So what is the likely condition? And I can see lot of C, Aditi saying C, Sukuna is saying C, Somit Gangopadhyay is saying C, which is diphtheria. Now, how do you know it is diphtheria and not any other, not membranous tonsillitis? Because membranous tonsillitis is the most common cause of throat membrane. Aphthous ulcer is seen on tongue or uvula or soft palate usually. These are the soft palate usually, not in the tonsil. This is in the tonsil. Tonsil has no soft palate, right? Tonsil does not have aphthous ulcer, sorry. Tonsil will never have an aphthous ulcer. But this is coming from the tonsil. Now these are the features of diphtherial membrane. These are the causes of membrane in the throat. So you can say membranous tonsillitis is the most common cause of membrane, and you can say that diphtheria is the second most common cause. You can say that, right? Now, as you are rightly saying, diphtherial membrane is dirty white, it is a pseudo membrane, it spreads out of tonsil. As you can see in this, it is spreading outside of the tonsil, bleeds when removed, causes bull neck. The neck becomes thick due to multiple lymph node enlargement. Multiple lymph node enlargement causes bull neck and produces neurotoxin. So these are the features of the membrane of diphtheria. It is dirty white, it is a pseudo membrane, it spreads out of the tonsil, that was seen in the image also. It bleeds when you try to remove, it causes bull neck, and neurotoxin does two things. It gives toxic look of the child. That's why if you remember in the image, in the question there is written it is a toxic look of the child, and it involves recurrent laryngeal nerve neurotoxin, and this causes vocal cord palsy, and vocal cord palsy causes hoarseness of voice. So that is why there is hoarseness of voice in the question, because of vocal cord palsy, and that is because the recurrent laryngeal nerve which supplies the vocal cord is involved, and recurrent laryngeal nerve is involved by a neurotoxin. Nerve is involved by neurotoxin which is produced by diphtheria, right? Now there was a question once long back that they had shown a similar image of a membrane in the throat, and the question read something like this: this membrane is confined to the oropharynx only, that is oropharynx area only, it has not spread out of the oropharynx, yet the patient has hoarseness of voice, which is a laryngeal symptom. Hoarseness is a laryngeal symptom. So the question was, why should a oropharyngeal disease not have spread to the larynx is causing laryngeal symptom, hoarseness? And the answer is this, that this particular disease produces neurotoxin, it can involve the nerve, and the nerve is passing from there. The nerve is passing from there, and so the nerve gets involved, leading to vocal cord palsy and therefore hoarseness. Right. Now, if they give you a diphtherial membrane of diphtheria, if they give you the membrane of Candida, Usually there will be a history of oral steroid spray use. They'll give you some hint that the patient is using oral steroid spray, so that steroid is depositing on the mouth, oropharynx or the tongue, and the steroid leads to growth of the fungus. So usually they'll give you that kind of a history. Aphthous ulcer, I told you the location is usually tongue or soft palate or uvula usually, but not in the tonsil like this, and it is most painful of the lot. The most painful condition causing membrane in the throat is aphthous ulcer. So it's very, although this one also pain is there, severe pain is written in the question also, it's a painful condition, but aphthous ulcer causes the most amount of pain. And Vincent's angina usually has gum infection also, and gum bleeding from the gum is also seen in these patients with gum bleed. So these are the hints about the membranes. When they show you different membranes, then this is how you can make a diagnosis what membrane they are trying to talk about, right? And this is how the membrane of, these are the two membranes of membranous tonsillitis. Membrane is also called streptococcal versus diphtheria, which we have seen. So if you notice the two images, in diphtheria there is a single membrane very well formed but out of the tonsil. In the membranous or streptococcal tonsillitis there are multiple membranes and they are patchy, not well formed like the diphtherial membrane, but within the tonsil, they are not going out of the tonsils, as you can see. And there is a very significant tonsillar hypertrophy in a streptococcal or membranous tonsillitis. So these membranes can be differentiated very easily from each other. In diphtheria, yes, the treatment of diphtheria is antibiotics obviously, and antitoxins, anti-neurotoxins, diphtherial antitoxins are very, very important in the treatment of diphtheria. In fact, antitoxins should be started immediately before the child goes into toxic look, because that can lead to serious consequences. So we always give antitoxins at a very early stage. So that's true, Vignesh, absolutely. Next question, question number 15. A 36-year-old obese person presented with very loud snoring with daytime sleepiness. Which of this is true of this patient? So obese person, loud snoring with daytime sleepiness, which of the following is true? This is probably obstructive sleep apnea syndrome. Polysomnography is the investigation of choice. Uvulopalatopharyngoplasty may be required. All are true. So which of the following is correct? See, diphtheria is a very dangerous infection, we all know. Fortunately, diphtheria incident has gone down drastically because of very, very active and immunization against diphtheria in early childhood. So diphtheria in today's time is hardly seen, and because it's a dangerous disease, whenever you suspect diphtheria, you should start neurotoxins even before you confirm the diagnosis. No harm in giving antitoxins, but if there is a diphtheria and if you delay in the antitoxin, then it can lead to serious consequences. Once the nerves get involved in diphtheria, then it is serious. If you can prevent that nerve involvement with the neurotoxins, antitoxins, then it is very helpful. So this is very clearly a case of obstructive sleep apnea syndrome. Everything, obstructive sleep apnea syndrome is seen in obese person. The main complaint is daytime sleepiness and tiredness, and snoring is a very important part of it. And in diphtheria, polysomnography is a investigation of choice, and uvulopalatopharyngoplasty is a very popular surgery done for this patient. So yes, all are true. But in obstructive sleep apnea syndrome, there are 2 or 3 other points that you have to know. What is the definition of apnea? What is the definition of apnea? What is the diagnostic criteria for obstructive sleep apnea syndrome? Any maneuver that you can do, and few points about before maneuver, what is the pathogenesis, you can say, and any maneuver. For diagnosis and detailed treatment. So these are the 5 things that you have to answer in obstructive sleep apnea syndrome. So apnea is described as cessation of breathing for more than 10 seconds. So Soumya Jha is nearly right. It's not about bradycardia. Bradycardia is absolutely a wrong term, nothing to do with bradycardia. So it's a cessation of breathing for more than 10 seconds. It's about breathing. The breathing stops. Bradycardia to baad mein hota. Okay. What is the criteria for OSAS? If somebody has more than 5 apnea per hour of sleep on an average. On an average, if somebody has more than 5 episodes of apnea per hour of sleep, then it is diagnosed as obstructive sleep apnea syndrome. So somebody is sleeping for 6 hours, there should be more than 30 apnea. 6 hours, if there is 30 apnea, average is 5. If somebody is sleeping 7 hours, the total number of apnea has to be more than 35. The average comes to be 5. Then it is called apnea. So if somebody is having 30 times in 7 hours of sleep, 30 apnea in 7 hours sleep, then we don't call it OSCS. Okay. Now, less than 5 is normal per hour. 5 to 14 is mild. 5 to 14. 15 to 29 is moderate, and more than 30 and more is severe. So there is mild, moderate, severe apnea. Now, what happens in this patient is very important. This is due to obesity. Now, if you can see my hand, this lumen, suppose this lumen of the hand is the lumen of pharynx through which the air is flowing. This lumen is sufficient. Now, when we fall asleep, deep sleep, all our muscles, whether they are smooth muscle or muscular muscle, they all relax. So the pharyngeal muscle also relaxes when you are sleeping. So pharynx is surrounded by muscles, constricting muscle, superior constrictors and all that. So this muscle of the pharynx also relax when we fall asleep. So when the muscle relax, they collapse the pharyngeal mucous wall, and your pharynx, which was normally like this, becomes small, narrow like this. This happens to all of us during sleep. Now from this much pharynx, if the pharyngeal mucous lumen has become this much because of collapse of the muscle during sleep, this also is sufficient for breathing. So normally we breathe through this also normally, and there is no problem in most of us. But if somebody has obesity and lot of fat has deposited in the pharyngeal mucosa also, the pharynx which was normally like this, because of deposit of fat in obesity, the pharyngeal lumen has already become narrow. And on top of this, when this patient falls asleep and the muscles of the pharynx collapse, the mucosa becomes almost negligible, very narrow. And through this very narrow lumen, the air cannot flow. And when the air is trying to push, it causes the vibration too much, and that causes snoring. So snoring is because of excessive vibration, because the lumen has become very narrow, the air is trying to push itself. That is one thing. And when the lumen gets blocked significantly, the air cannot reach the lungs. So, and from the lungs, the air cannot reach the oxygen cannot reach the blood. So there is hypoxia, the oxygen saturation fall, and hypercapnia, the CO2 level in the blood rises. O2 falls, CO2 rises, and when this CO2 reaches the brain in the sleep to the blood, the brain, when it gets high CO2, hypercapnia, it gets agitated. Brain knows that this is problem, and the brain tries to wake up. The patient is not completely awake, but partial consciousness is gained. When the patient becomes partially conscious from the deep breath, then the muscle again becomes tight. The muscle again becomes tight, they again starts functioning properly, the lumen again becomes white. And now again the air starts flowing normally. When the air starts flowing normally, again the oxygen rises, CO2 falls down, the brain relaxes, the patient falls asleep again. When the patient falls asleep again the same thing happens, and this keeps on repeating throughout the night multiple times. And when this happens more than 5 times per hour of sleep, we diagnose this as OSCS. And that's why the patient has not got the proper sleep at night, and that's why daytime sleepiness is the very, very important thing. Polysomnography is the investigation of choice that is going to diagnose this disease, polysomnography. But you can do a maneuver called reverse Valsalva. Reverse Valsalva. In Valsalva, we block nose and mouth and try to blow. In this case, we block the nose and mouth and try to inhale more air, pull in, and this maneuver is also called Muller's maneuver. It is called Muller's maneuver, which can be done for OSCS. In the treatment, weight loss is the first thing we divide. We use CPAP machine, we use BiPAP machines, and we do surgery like UPPP, which is uvulopalatopharyngoplasty. So these are the additional points about obstructive sleep apnea syndrome, right? I hope this tells you important points about this disease, and there have been questions from here in the last 10 years 2 times, so it's an important topic, you understand that. So we have reached a landmark of 15 questions and almost 2.5 hours of our class. So I think it's time to take a break here. So we'll take a break for 30 minutes. Exactly at 30 minutes from now, that is 7:10, I will start the class. Okay. So please have a cup of coffee or tea, wake up and come back after the break. So till then, enjoy yourselves.